All right, we're live and recording. So if during the lecture anybody has any questions or anything that they think they could add to enhance it for yourselves or your classmates, remember you can always go back and reference this during your registry prep. I hope you've been spending time on your apps and your test generators. Get yourself comfortable with these formats. But all year long, we've been testing you. See what you know, what you don't know. Remember what the test is for. It shows you where you're lacking things at, so you can fill those gaps. If you're just taking tests and you're not going over things you've missed, then you've missed the whole idea of what testing is about. So at this point, I know you guys will go and do a great job on passing registry. The real test is when you have a patient. That person in front of you, you'll need to know what to do for them. Already, you've probably seen some of your new knowledge kick into play, and you've seen some of the questionable ethics of some of the medics you rode with as preceptors. That is not what a paramedic is supposed to be, one that withholds pain medicine or is unethical or does what's comfortable for them. You're not there to have your own opinions about medicine. You're there to be an objective third party that provides first responder medical care in a pre-hospital setting. So I'm sorry y'all had to have some of those situations, but I'm also glad because it taught you to never be that type of medic that will withhold pain medicine from somebody had their fingers cut off. Now you know not to ever do that to a person. So giving you that ownership over it that we said on day one is if I pick up this patient, why they're with me, their family. So let's have an example. Mr. Laughlin, if I picked up, let's say your mom and her fingers are cut off, right? Should I give her pain meds for that? All right. Would you give her pain meds for that? Of course, right? So if I pick her up and I'm treating your mom like my mom, would I then therefore give her pain meds? I would, because I'd give my mom pain meds. What about somebody's mother, brother, sister? While they're with you, that's your mother, brother, sister. So if you would do it for your family, do it for others. So I'm hoping you guys will be a better version of the paramedic and what they're supposed to be. Keep in mind that burnout does happen. It's important to take the time to recover your senses. Use your PTO time. A friend of mine died of COVID about 5 or 6 months ago. He was a kind of a retired paramedic. He had super low numbers, like in the 2000s. He'd been doing it for 25, 30 years. He became a dispatcher. And I remember when I was in operations command, my wife would bring my then only child, my 1-year-old, up there to visit with me. And, the guy was, extremely pleasant. He enjoyed playing with her and he used to give her candy. He was just very kind to my child. And I've known him for years. And as head dispatcher, and I'm a brand new operations manager who has no clue what he's doing, he took a lot of pity on me and may try to do anything that made me look too stupid. He was a very good man, but COVID killed him. But guess what? Before his obituary posted, and I kid you not, his job was available on the company website and on Indeed.com. It's nothing personal, but you're ones and zeros to your organizations. I'm a 1 and a 0 here, but at home I'm dad, I'm husband. At home you're the dog's best friend, or your dad or mom or sister or brother. So I want to encourage you guys to not let this job burn you out or take you somewhere mentally you don't want to go. And it's okay, again, not to be okay, to talk about things, to get help. We got to break that stigma early on. So I want to keep that encouraged. Here at the end, I hope you consider me a resource you can tap into anytime. You got my phone number, my email, it's up to you, Lachlan. If you need anything, call me. A lot of you called me or text me during your calls when some stuff was going on. And if I was awake, I gave you the best assistance I could. So moving forward, that's always an option to you. So let's talk about the medical section of the National Registry and how we can therefore see this section during the registry and then kick its butt. So does everybody remember the electrolytes that make up the intra and extracellular body? Anions and the, what's that? and cations, very good. So the anions we would talked about would be inside the cell, would be phosphate. Extracellular would be what? Chloride and bicarbonate. Extracellular is outside the cell, very good. Extra, exit, outside the cell. Again, it ain't stupid if it makes sense. If it works and helps you remember that it's not inside, intra is in, extra is exited outside the cell. That makes sense? Oh, sure. All right, the cations, intracellular potassium, right? That's the most abundant cation inside the cell. I kid you not, I have seen that on Registry, April 2020, when I went and retook it. I've told y'all that before, but it very well could come down to a pathocellular question. The Registry test will adapt itself to you and where you're at as a provider. So it is very important for you to keep in mind some of these extra patho things. You know, it's crazy to me that paramedics are responsible for this much patho knowledge, but our treatment pre-hospital is like this right here. While I think it's important as a paramedic to know that asthma is a disease of inflammation, production, and bronchoconstriction, if I hear wheezing on the streets and they can't talk and tell me their history that they have asthma, I'm still going to bronchodilate them, probably go with a steroid if they have no kind of contraindications to a mag drip, do a smooth muscle relaxer, am I not? So keep that in mind. And when you're in the streets, don't let the patho trip you up. If you see a problem, treat a problem. Your assessment will guide you to how to treat these problems. See a problem, fix a problem. Do we fix problems that we don't see? Do I just do exploratory needle chest decompressions? No. Do I just do exploratory surgical crisis? Well, he might have an airway issue. Let me go ahead and just cut his throat open. No. I have to have a good reason. I got to be able to defend that reason. I can't pull some unnamed hospital agency that would perform a surgical crisis in the state of Georgia where only a needle crisis is allowed. No comments. So inside the cell, potassium is the number one. Outside the cell, sodium, most prevalent, extracellular cation. Let's define the terms hypokalemia. Hypo meaning low, kalemia meaning potassium. Hyperkalemia, we've talked about that a lot, especially when we came to EKGs, right? So we could start seeing with hyperkalemia, elevated potassium levels. We could see what? All right, so widened QRS, tall peak T waves, and eventually we'll see that sine wave that'll turn into V-fib. I wholeheartedly want to avoid all of that. Usually these patients are ones that have missed dialysis for a few weeks. And it does happen a lot. Here in the city of Atlanta, there's a lot of diabetics, a lot of kidney disease. And it does happen a lot. And I promise you, you will see this out there. All right, you was talking to one of your medics.
Yes.
I'm going to repeat what you're saying because I've noticed in the feedback when I do the videos, it's hard to hear your voice. So I'll make sure that.
He was telling me he had a patient with a small peak.
Right.
The patient was conscious, but he said he gave them sodium.
Bicarb.
Okay. I know he's for sure he gave them sodium, but they wasn't like conscious or whatever.
Right. So you can give bicarb and calcium chloride to a conscious patient. In Fulton County, you had better have orders to do it.
Exactly.
Because if you give calcium chloride too fast, it can send them into V-fib. You give sodium bicarb too fast, it can cause a lot of issues as well. So we got to be very careful with the administration of that. Bicarb is going to be given over 5 minutes very slowly. Calcium chloride will be given over about 2 minutes, very slowly, very carefully. They're going to be very uncomfortable and they could have a whole slew of side effects from the administration of that if they're a conscious person. So those words in our protocols around here are written in red. If it's written in red, it's very important. That means call med control and get permission to do it. I've had it happen a lot, and they've never gave me permission to do it on Zoom. They were like, "How far are you?" I'm like, 10 minutes. They're like, "Just bring them here. We're going to dialyze them and watch them and monitor them," because I don't have access to lab values, right? I don't have access to knowing what other kind of toxicological issues they're having because their kidneys are not filtering their blood, right? So it's much safer if they do it. But remember, calcium is cardioprotective. It will protect the heart from going into V-fib. So what we can do is run some fluids, do supportive care. I'd prep for a code, but I would try and get them to tertiary care as fast as humanly possible and safely.
So saying, supposing that they code.
Oh, once they're dead, they're dead. You can push it as you want.
Probably want to jump on that early on.
Yes.
Obviously, we're clear about.
Yes, you would want to follow ACLS protocol as well. But it's the quicker you get the calcium in there and the bicarb, the quicker you could deal with that H and T that caused the arrest. So when you do get that ROS back, because you're doing pitch perfect CPR, managing airway very well with capnography, and possibly defibrillation, once they come back, they can stay back with you. You know, but just be very careful. We don't mix the two in the same IV without heavy flushing. Preferably you'd have 2 IVs, but that's preferable in a perfect world. I'm looking to get 1, right? So just be sure you have flushed that thing incredibly well. That way you don't run into any type of big issues with that. All right, so we talked about the neurotransmitters for our nervous system. We've been talking about sympathetic and parasympathetic all year. Just about 50 billion times we brought these guys up, right? So let's not forget that neurotransmitters are essentially the fuel and delivery system of the sympathetic or parasympathetic nervous system. So parasympathetic nervous system runs off of acetylcholine. In the sympathetic nervous system, its neurotransmitter mainly is norepinephrine. One slows the heart down, one speeds it up. Thomas, tell me who does what. Who belongs where? Yeah, you.
I'm trying to.
What
did you ask?
You trying to stare off into space?
No, I was doing it.
Okay.
What did you ask?
So I'm asking about the sympathetic nervous system's main neurotransmitter. Anybody with the right answer? Norepinephrine. So acetylcholine belongs to the parasympathetic. Remember, it slows things down. All right, so I threw this in here for you just to be aware of, that you might see these things on there. Murphy's sign, Keir's sign, McBurney's sign, heel drop sign, cough sign, Cullen sign, Gray-Turner's sign. This is all of the ones that they could throw at you. The main ones I would say are Murphy's, Keir's, McBurney's, Cullen's, and Gray-Turner's. I've seen some of them on Registry before myself. Again, the more you know, the better you'll be at it and the better you can identify and recognize these things. However, those are the main ones I have seen on there. This lecture PowerPoint again, you guys can take it, use it, hear through it, go through it with me through the videos or whatever, but these are the main ones we will talk about. Murphy's would be what? A sign of cholecystitis. We got the right upper quadrant pain, tenderness, it might radiate to the shoulder. All right, Keir's sign, left shoulder tip pain, usually a ruptured spleen, especially when the patient lies supine. McBurney's point, you remember McBurney's point, we're talking about what? Appendicitis. So that's the sign between the right lower quadrant and the iliac crest of the hip. Right there between those guys is McBurney's point. They got pain there going on. They got right lower quadrant pain. They're kind of sick, pale, cool, clammy. They might be looking at some appendicitis. You can also do a jump test. Yeah, appendicitis can have a lot of things going on. So pulsatile masses, obviously an aortic aneurysm, AAA. They got chest pain and radiation to the back. The big registry wound would be what? It is described as a tearing sensation. So again, when you're taking these written registry questions, don't read into them. What is on the paper or the screen is exactly what's going on. Try not to overimagine anything else going on. The answer to the question is on the paper. It's on the paper. So appendicitis, inflammation of the vermiform appendix, junction of large and small intestines, usually happens in the adults. So acute appendicitis is most common surgical emergency in the field. A rupture leads to peritonitis, which is life-threatening. So what happens is what? The appendix bursts and ruptures. A lot of that fecal stuff and those bacteria get into the peritoneum, it irritates it, and you could become septic. bad juju, right? So recognition of what's going on and that's a true emergency is paramount for you to treat it. Now, do they need you being rescue Randy on scene, or they need a surgeon? They need a surgeon. They don't need you playing around. So right lower quadrant pain at McBurney's point, they've been kind of sick for a day or two. It's really tender. You actually have them jump up in the air and they land and they have a lot of pain down there, like even more so. That is a sign of a positive jump test, which means what? That appendix is inflamed, and once he hits the ground, what's it do? Kind of waves in the air and hurts, right? So after that, we need to hightail it to the hospital. Go ahead and get some IVs for them, some fluids going. If they're nauseous, what can you do for them? Zofran or Phenergan. What's our dose for Zofran? What do you think? 4 milligrams, usually located in a 2 ml vial. Again, it could be packaged another way, but the most common way we see around here is 4 milligrams and 2 mLs. Now with Zofran, you'll be careful giving it because it can cause prolonging of the QT interval. So a lot of services like Grady prefer you do a 12 lead before and keep them on a monitor while you're doing it. Allergens. The dose for promethazine or Phenergan is going to be 12.5 to 25 milligrams, depending on the patient. Now, what is important to remember about Phenergan is not carried a whole lot anymore, not a whole lot. The thing important to remember about it is it needs to be diluted. Draw up the medicine in a 10 cc syringe, just a flush, and give it, and it works for dilution. If not, it'll be instant phlebitis. It's very, very caustic to the veins. So it'll be like acid going through their IV port. They will not like you. You may get punched. You will deserve it though. So Phenergan does have that synergistic ability with a narcotic. You mix Phenergan and morphine, it makes 2 + 2 = 6. So morphine's way more powerful. That's something to remember. But I don't know anybody around here carrying Phenergan anymore. Other states may carry it, but nobody in the Atlanta area is carrying Phenergan. Unless I miss my guess. What about you, East Point? Y'all got it? The rest of you. What about Riverdale? What y'all got down there? Okay, Zofran's a good one. Zofran does a lot. I just don't want them to puke on my booty, right? I just want them to be comfortable, take their nausea away, and have a decent ride. You know what I'm saying? And if Zofran does that, as long as you carry something. Very good. I'm recording, sorry. if I'm being weird and like trying to articulate a little bit more than I normally do, not only slur things together, you kind of got to pick up the murmur of it. But yes, like a 25 milligram of Benadryl can work for nausea sometimes. Yes. And you working at Grady over there, you would know that their protocol for a long time is they won't give Zofran to any woman of childbearing age with a possibility of a cleft palate. So that we would always give the Benadryl in lieu of Zofran. But as long as you don't have nausea and you don't puke in my truck, I'm fine. Whatever vehicle gets me there, right? That's good enough. I mean, that's what's written. What they doing on the street might be a whole nother thing. As long as you can justify it or get the doctor to sign off on it, you can get away with a lot of things. As long as you have med control backing you. And a lot of these pregnant ladies, they give it out like candy. Zofran, I mean, most of the hospitals, the ER, Zofran for you, Zofran for you. I bet you did. So long as you get somebody to back you up on it that has an MD behind their name, you should be good. But we do have to kind of operate within our scope. Just be careful with that. That's all I'm almost saying. So allergens, I told y'all, remember which antigen caused allergens, right? That was IgE. I've seen that on the registry. That's the main one we want to talk about. So what happens during this allergic reaction, anaphylaxis, all that kind of stuff? Let's talk about it. So let's say a bee stings Mr. Thomas over here, right in his forehead. Bam! It releases the toxins into his body. His body recognizes that this is a foreign antigen. It releases antibodies, right? Those antibodies are the ones I use. They'll go to his mast cells. and his basophils and degranulate them, releasing histamine, which causes a lot of the problems that we have during an allergic reaction. It could be localized or it could be systemic. The systemic would be worse, right? Because now we're involving a couple more body systems than just the local erythemic skin irritation. So let's say you've got an allergic reaction versus anaphylactic. What would be anaphylactic shock versus allergic reaction? When the blood pressure falls, when he is now hypoperfusion. Shock is hypoperfusion. So when he starts to hypoperfuse, now he's in shock. It's an allergic reaction before that. So let's talk about some of the signs. Let's talk about allergic reaction first and work our way through it. So, okay, urticaria, so hives, itching, all right, wheezing. It ain't easy being wheezing. All right, and tissue edema. So what all this causes, the histamine release causes vasodilation, bronchoconstriction, increased gut motility. A lot of the fluid in the vascular bed will shift out of the vascular bed and go into other tissue. Some of that tissue is where? In your throat. So that laryngeal edema will cause the glottic opening to be closed. Our job is to intervene before any kind of big bad juju happens, right? So we're going to go ahead and hit him with that epi shot. What's my dose? 0.3 IM, right? Of the 1 to 1,000, the 1 to 1,000, right? All right, a Benadryl, he needs to come in there too. Benadryl and histamine blocker, right? So I need some histamine block because this is the one causing all the problems. What's my dose? All right, 25 to 50 milligrams will take care of that. Blood pressure starts to fall. I need to give him a bolus of fluid. 10 to 20 cc's per kg. That should help out. What if I hear wheezing? Albuterol is an option. Epi should be doing, epi would be a good idea. You know, it should do some of that bronchodilation. We want to be careful when we're talking about giving a beta agonist on top of epi. Even with giving the epi, you need to watch out for hypertension, tachycardia, and arrhythmia, right? So if you're going to talk about giving albuterol as well, be very careful and make sure that, one, you've got med controls backing, but two, you can justify. Now, we've got systemic inflammation going on. What kind of medication are we talking about here in this area? Systemic inflammation. What kind of medicine would I talk about and think about giving a patient? Decadron, very good. So a glucocorticoid steroid. The one we use most commonly around here is Decadron or dexamethasone, or as we call it, old crotch burner. If you don't dilute it, even if you do dilute it, it will cause perennial burning. Well, solumenadrol would not cause the perennial burning. Did you see it happen? It was like crouching. We got an uncomfortable heat feeling, right?
Yes, she had a heat feeling, and she had taken it.
You knew it was coming, good. Always try and warn your patient that it's coming. So if you dilute it, it's an uncomfortable heated feeling in their crotch area. If you don't dilute it, it's a burn. It lasts about 30, 45 seconds. Still, you want your patients to be comfortable, right?
So Decadron is the burn.
Depends on where you work. Okay, children.
And I didn't even give them
Dilution.
I'm wondering if that.
It's possible due to the reproductive issue, differences down there anatomically. It's also possible due to the amount they, I don't think they're giving 20 milligrams like we are. The dose for Fulton County is 20 milligrams. And
I was surprised.
Yeah, I mean, I don't know what the difference is there. But it's a good drug. It does knock out some inflammation. And that's what they need if they've been having an allergic reaction. Now, worst case scenario, you could create a dirty epi-drip to do continuous epinephrine administration for these patients. Again, tachycardia is an issue, arrhythmias, blood pressure, watching those and getting permission to do the epi-drip. I don't think you have it here in Fulton County to just do an epi-drip for an anaphylactic reaction.
oil.
Mhm.
Do it into a 20 bag. Next to it for it.
Or mites. That's how we do that. All right, so some common allergens are drugs, food and food additives, animals, insects and insect parts, fungi and mold, sometimes radiological contrast materials. There's people with allergies to all kinds of sorts of strange things. Some people, of course, are more susceptible because they have allergens that are more commonplace things to happen, and some people are only allergic to very uncommon things. Does everybody know their allergens at all times? No, it might be news to you that day you find out that you had this allergen. So you could get it through oral ingestion. You could eat it. You could inhale it. It could be gone through your skin, injection, or envenomation. So most anaphylaxis results from injection or envenomation. The number one cause of anaphylaxis is what? Parental penicillin. So a penicillin shot. And then insect stings will be number two. Yeah, penicillin is number one. So we've already talked about all this. I won't sit here and beat a dead horse. We've already been through all that. As you're studying though, make sure you're looking through this, make sure you understand anaphylaxis and the how, the when, and why we treat it like we treat it. So just make sure you know the how, the when, and why.
I remember seeing a question as far as like how long does it take? Like, like simultaneously, or like 15 minutes, 30 minutes?
You know, that's very subjective to that person that was injected. Is it their first time being exposed to it? Is the body going to have an exaggerated response this time? Is it going to go full-blown anaphylaxis? You know, it really depends on that person. I would say you would know something within minutes.
Like 30 minutes.
I would say within minutes to hours. I mean, let's say you eat a peanut and you're allergic to peanuts. You know, you could start seeing some effects going on immediately. But once it hits that small intestine and it starts to be, you know, spread out and dispersed to the rest of the body, now we're going to talk about some big systemic issues going on.
Well, isn't it your first exposure to it? It's not like an actual response where you haven't developed the antigen.
Correct.
Antigen isn't created until after your initial.
Correct. So sometimes if it's the first time you're exposed, your body will overreact a little bit, but it ain't gonna be bad. The next time your body sees it, it's like, I remember you sucker, let's go. It releases a full-blown oversensitized immune response that just causes all these issues. What about psych patients? Well, here in Atlanta, that is our forte. Dublin, come preach. All day, every day. Now, what I want you to remember, though, is to treat these people like people. I had to remind a partner of mine one time. He's like, I'm tired of all these God bless homeless people calling and blah, blah, blah. Let's stop. Let's take the word homeless people, remove the word homeless, and let's just say people. They still people, and some of them have some amazing stories of how they got to where they got. And I can promise you, a lot of us are only a couple of life choices away from being pretty close to that ourselves. You know what I'm saying? A couple different things went a couple different ways, and we could have been on the streets too. Not Lynn, though. He'd have been stripping by now. So, he is an old professional. But he won't go hungry. There you go. Around you. Moving forward with psych patients, speaking of. This is behavior that interferes with core life functions. So your job, you know, your love life, your marriage, you know, your work relationships can be affected by this. Poses a threat to the life and well-being of the patient or others. Behavior that deviates significantly from society's norms or expectations. Now, I could say, Mr. Lachlan, crazy, right? Because he doesn't act like me. But isn't my assessment of that kind of subjective? Some people are just a little weird. I don't mean they're psych patients, right? Just because my sister-in-law is really into cats and will probably have 50 of them by the time she's 40. Does that mean she's a psych patient, or is she just destined to be that cat lady? Borderline. He's on. So some of that's subjective. So when do we come into play? When does it constitute emergency medical services to get involved? When they're a danger to themselves, others, or if PD don't want to transport. Scratch that from the record. But definitely when we want to get involved is when we can justify getting involved and when that patient is a danger to themselves. We all watched the video of Mr. Paul Tereship, the man that went down to South Carolina and he was neglected. And because of the EMS's negligence, you watched it. He died because of their negligence. So if I'm called on the scene, I am medically responsible for that patient, especially a psych patient, until I do what? Transfer care to somebody else. Now, Paul Tereship was not aggressive or violent. He was very compliant. He probably would have sat in the stretcher, put the seatbelts on, rode to the hospital and gotten the care he needed, right? You know, ain't nothing wrong with keeping that thing on, you know what I'm saying? Sedation drugs handy, but he seemed like a cool customer. But I have had them flip on a dime. That don't mean they won't. If you stay ready though, you ain't got to get it. I expect it, but I hope it doesn't happen. But I have met many a psych patient out there on the streets that were a danger to themselves or others. They're suicidal and they're refusing to go to the hospital. So as long as I can justify it, I can do what? We can have involuntary consent happen and we can take them to the hospital. If you're ever in doubt though, give a shout. Call your med control, call your supervisor, get them involved and pass the buck a little bit. By that, I mean, get somebody else with a higher education or pay more money to help you with this decision. Yeah, he's certifiable. You know, sometimes though, you may not have time to make a phone call, right, Dublin? You may just have to ask for forgiveness rather than permission. He tried to bite me, so I sedated him. In the story. With the tongue. I'm kidding about that. Scratch that from the record as well. The good old 5 and 5 works well. Sometimes 10 and 10 is required. I've noticed here at the Citizen of Atlanta, I've started a bit of immunity to the Haldol. It might be time to upgrade to ketamine or Geodon or something. However, if you do it, make sure you can justify it. So there's all types of things that can cause it, biological, psychosocial, sociocultural can be a cause of it. So we've got delirium, dementia, schizophrenic issues that are coming on, hallucinations, disorganized speech. We have picked up patients that are literally seeing little green men. I don't want you to play into their delusions and make them worse, but you also need to account for your safety as well. You know what I'm saying? Again, we talked about it. We talked about, let's say this is a black pen, but Thomas only sees a red pen. In his mind, as a psych patient, he can only see the red pen. Exactly, it's because it's red in his mind. The rest of us see a black expo dry erase marker. But I can't convince him otherwise. So I need to accept that and not sit there and try and lecture them on scene. Let's go get you some help. I know you're seeing red. This is actually a black pen, but let's talk about it. We got people that can help you with this. You know, try and use therapeutic communication. You know, don't try and tell your life story. Don't try and, you know, tell them that you've had it worse. There's no reason you should be like this. What about the college girl that's freaking out about her exams, having an anxiety attack? Does she want to hear about your life story, how you've got it worse and you're on a 24-hour shift? Is that going to really endear her to you?
No, it's not that bad.
Right. That won't piss her off at all. So, the best thing I found for that is to change their focus, let them focus on breathing, get their mind off of it, and you know, that usually helps tremendous. Therapeutic communication is very, very, very good for this. What about excited delirium? If you're going to physically restrain a patient, you need to chemically restrain a patient. Why? Excited delirium can happen. Patients struggling across all these restraints, right? It causes a systemic acidosis. They throw an arrhythmia. They go into cardiac arrest. Your patient's thrashing, and suddenly they're quiet. They've gone into arrest. If you physically restrain, you need to chemically restrain. Trust me on this. Good to know. All right, panic attacks. We kind of talked about that a few minutes ago. I mean, does everybody have anxiety to a degree? Has everybody got a moment to where things might get out of their head, get in their head a little bit? We've all been there. So we can all be a bit understanding. My partner at Grady, man, he used to get out of the truck at a post. We're posted, nothing's going on. He'll start pacing. I'm like, what's the matter with you? And he's like, he told me he was having an anxiety attack. You can't plan these things. You can't, sometimes understand them. You can only deal with them. And learning how to ground a patient is very important. That really comes down to therapeutic communication. There is protocol for you to sedate these patients here in Atlanta anyway, but I've been really blessed to never have to do it because I would always talk them down. Now, it may be only for a short period of time, but as long as you're continuing to do it, it can be very helpful for them. It can be very helpful for them. So anxiety, somebody define it for me. It's when you're making, okay. The bucket fills up. Elaborate for me. A lot of stress, it just tips over, right? The bucket fills and it tips over and you now feel maybe a bit overwhelmed. I may have at one point in my life been a bit hyper masculine and chauvinistic where I'm like, get over it, man. What's wrong with you? Punk. But then I had an anxiety attack and I'm like, wow, I feel overwhelmed and it's something actually kind of small. I haven't cut anybody in a long time. I still got my sedation skills. You know where I'm at. Don't judge me. See? So I'm a lot more understanding now. So how else can we describe anxiety? Possibly where the world of the imagination is creating more problems than the actual world is giving you, right? It's a lot of it's in your head. A lot of us overthink things and think way ahead of things. It's not actually happening, but what if it does? We what if ourselves to death? So it's important to not only understand that for our patients, but for ourselves too. All right, so how do we check mental status? So AEIU tips is a mnemonic to rule out reasons for altered mental statuses. I would also advise you to commit that to memory. So understand that if they're altered, it could be alcohol, epilepsy, insulin, overdose, uremia, trauma, infection, psychogenic, and stroke and syncope could be reasons for that. Who remembers what decorticate and decerebrate posturing are for? Okay. So posturing would be possible herniation or a lesion on the brainstem or an increase in the cranial pressure or something like that, right? Okay.
I think
There it is.
So you see, yeah, that's when it worsens. That's when it worsens.
So decorticate toward the cord is bad. So that's when they're posturing in like this. Decerebrate's when their arms are spread and they're trying to fly to Jesus, because that is a later sign, usually meaning impending death and arrest, right?
I really only see the decorticate.
Well, they're not in decorticate posturing. They have what's called contraction, right? Their limbs are, unless they've got a head injury and brain herniation going on. Are they like that 24/7? All right, so their arms are just contracted like that.
Cerebral, yeah, that's when the brain skin. Right? That's when I got the brain skin.
Yeah, possibly trying to push the brain through the brain matter.
For the AEIO2, I don't know what you're reading.
UTI?
Oh.
Some type of urinary issue causing possible sepsis, possible altered mental status, something like that. So we talked about the excited delirium patient. I borrowed this post from an Instagram. The person's name is the pre-hospitalist. I think they're a flight medic, but they do a fantastic job with putting things together. And I hope they don't mind me sharing. If they do, I'll definitely take it down. But I definitely enjoy what they do, and I think you would find it very interesting too. So, excited delirium and the triad of death: hyperthermia, rhabdo, and acidosis. So, why would somebody enter excited delirium? This is that psych patient you can't calm down. This is that 130-pound guy that's strong enough to throw 5 of us around and snap their restraints like they're made of paper. This is that guy. It takes 10 police officers to pull him down and hold him. These are people that could be on cocaine, meth, PCP. PCP people are strong, super strong. LSD, bath salts, K2, schizophrenic, bipolar, or they're not taking their psych meds. This sounds like a Saturday night here in Atlanta to me. The triggers will be increased dopamine in the brain, increasing hyperthermia and the sympathetic response. So their body gets heated, they're hot, right? This is that patient, they're red, they're sweating, and they're like super amped up. And you get there and they got an increased sympathetic response, which means their body's doing what? Dumping adrenaline. Heard about the little lady that can lift the car and pull their kid out from under it? This is the psych patient that can lift the car and you and throw you both through a wall. Yeah, enjoy it. So they have hyperthermia, diaphoresis, tachycardia, increased strength, and then increased strength, and then they're stronger than hell. And then a 130-pound guy throws me, a 290-pound guy, off of him like I am just a baby. And there's 4 or 5 people just like me on top of him, trying to not let him kill us or himself. They also have an increased pain tolerance. You can tase these people and they may be unfazed. Now we talking. Love it. Now I'm real pissed. Good job, PD. Stirring the pot. All right, so agitated, violent, and they may have incoherent speech. They may not make sense. The things that will kill them: hyperthermia, hypermetabolic state, increased dopamine results in hyperthermia. Their body temperature starts to rise. Rhabdomyolysis is what? The destruction of skeletal muscle releases myoglobin, right? Which can cause an acute kidney failure. So it clogs the kidneys with big fat storage proteins, and it can cause acute renal failure. Acidosis: the patients exert themselves beyond normal physiological limits, resulting in metabolic acidosis. So what's going to happen then? They're going to arrest. They're going to arrest. Physical restraints increase the risk of sudden death. Fighting their restraints makes the triad worse. Chemical restraint can be life-saving. Why is that? Calm them down, knock them out. I would rather bag you than fight you or have you hurt yourself and or me, and maybe my partner if I like it. You can beat fire up all day. So,
body doesn't try to basically shut itself down.
overwhelmed.
We think really just this that's going on would just be like something like a kilogram, be like so.
The amount that it will release would not be able to counter the amount of sympathetic release that's going on, especially because they've had some help sometimes. Cocaine, meth, PCP, bath salt. If I'm not only having my own adrenal sympathetic response going on, now I've got this synthetic stuff, I can be up even more. It'd be really hard for my own body to compensate for that, especially if I've been doing it for a long time and I've wore out any kind of like compensatory mechanism I would have. Maybe this ain't my first time on bath salt. Maybe it is. So we make sure. Okay, that's true. It does have some controversy. You're right. So do we ever restrain a patient prone? No, even mall cops know that. Let's not get too off track here. So in the EMS world, let's say you see some police officers who are doing that. So what would you want to do really quickly? Go ahead and get the needle out, sedate them, then we roll them over onto their stomach so they can expand their chest and breathe. Sit them up if possible. It will be on us to mitigate those circumstances as best we could.
And then also how to sedate, because so when I was writing pathetic, I mean, he was just not right. He wasn't ever fine, but medic called cycle. And then I wrote again, and they're like, ketamine, you should not get ketamine, schizophrenia, you should not get ketamine. Those were contradictions. But then, from what I've researched, it's not true. So
Do I sedate somebody just because they're mean to me or because?
doing even me, he was just like, he was out of it a little bit.
So was he a
doing
danger to
sit-ups,
himself or others?
she was doing shit.
But was he a
But
danger?
he was foaming out. So
Okay.
he looked a little crazy, but he
Okay.
wasn't hurting himself, he wasn't hurting anybody else. He just couldn't get him up. He was lying there, rigid. Looked like maybe he could get angry, but he didn't actually.
So it was a sedation more on the what could happen, right?
Right. But even just the term, even just whether it's
Interesting. So sometimes we run patients that you don't have to knock out, you can just knock down. Let's take the patient that's overdosed on a bunch of cocaine and they've got like a sympathomimetic syndrome going on where their blood pressure's through the roof, their heart rate's through the roof, and they're red, they're sweaty, and they're just like having a big old sympathetic response. But I need help, man. He's talking to you. He's not like out of it. He's just like, I'm really messed up. I did cocaine today. I'm really bad. I'm sorry. Please help. So he's asking for help, right? He's not like, chewing on the stretcher and like trying to stab me in the neck with, a cactus or something. I could just give him some Versed and knock him down and not out. We have a couple of gray areas when it comes to these guys, to these behavioral patients, and we want to do what's best for the patient at all times. So when we hit that gray area, we have to remember to be an advocate for the patient. Do I have to do this? Versus do I want to do this for their safety, but also my safety? I can tell you now, when I first started working in Sickle Atlanta, I got punched in the mouth a few times because I wasn't aggressive enough with the sedation. After that, a couple raps on the beat, I'm like, all right, I'll just keep this thing right here in my pocket. You can get it if you want. But I would always want to be able to justify in my documentation and to the patients, like let's say I had, sedate your friend Lachlan here, and you were asking me about why I did it. I'm going to be able to justify to that patient's family or friends and that doctor that I was taking to why I did this. Right?
Well, everything was rigid and so pretty much even after the 400 that we gave him, he stayed that way.
Right.
The hospital ride, and then to the end. Precious, we had to bag him because we were getting out the stretcher.
Well, there's that.
But in the hospital, they were like, "Why are you getting so much?" So they were a little irritated, but then he started acting rigid. But like I said, I wouldn't consider him violent. He didn't.
Is it possible that it was not a psych call, but it's a seizure?
It's possible.
I mean, it was
They
not a
did say
full-blown-
he was on cocaine.
Okay.
His roommate did say that.
Are they good historians? We're taking a lot of this at face value. It could have been just a petite mal seizure or tremors. It didn't sound like it was grand mal at all, but there's a lot there. I'm not going to say that I haven't sedated patients for my own safety. Like I get there and he's hurt because him and 5 PD officers have been into an altercation. He done tried to fight them. You ain't about to do it with just little old me in the back of the box. And another thing is I worked at Grady. I'm taking him to Grady. I'm taking him to my house, my place of business. The nurses I work with there, they're my friends and colleagues. I'm not going to let him go in and hurt them because it has happened. Medics brought a patient in who was violent with them, talking smack. They get up They try and stab a nurse with a pin, actual patient, and then they punch out the ATM screen of the machine in the lobby as they're kicked out.
Naturally have that call.
That exact call has happened a few times. Y'all remember we're doing your clinicals at Atlanta Medical Center, right? Did y'all see some nurses get attacked and hurt? Some of y'all did. Some of y'all told me.
They were all preemptive, yeah. But, yeah.
So Dublin, you've seen one, right? A little bit louder for the people in the back of the camera.
Yes. Punch the nurse in the face before security got to him.
So it was interesting. What did you do?
You didn't do nothing.
He was like,
I ain't here. I'm a student. I remember that nurse was mean to me one time. So, man, it's a razor's edge to walk, but I've always been very blessed to be able to justify it. I wouldn't do it to somebody that didn't need it, but working weekend nights in Atlanta, man, it kept that thing on me. I'm not kidding. You know, the little gray shirts with the pocket on the top, right? There was a needle in that top left at all times. It wasn't a question of if, it's when. Who gets it? All right, so I got a couple of doses here for you if you wanted to treat these patients. You got Haldol, Versed, Midazolam, Ativan, ketamine doses for that. Really depends on what your service does. Just make sure you know your service's agitated patient protocol very well. I ain't gonna lie, I ain't been sneaky a few times. I went to the MARTA police station, that one in there at 5 Points where they keep you sometimes. This guy was on some PCP. He was a tiny little old man, right? And MARTA PD looked worse than he did. There was like 5 of them. There was a bunch of them. He had already ripped the handcuffs out the wall, the stone wall. He was walking around with them dragging on the ground inside the cell. And they opened the doors like, he's in there, go get him. I'm like, I ain't going in there. Now, you go get him. I see what he did to y'all. So I asked him, like, hey, buddy, you hurt? He's like, yeah, man. And he started talking about how they hurt him. And then he started talking about pink dragons and stuff. And I'm like, okay, I got some pain medicine for you. You can bring your shoulder to the door. He came over there. Whoop. Now, I did tell a little fib because it wasn't, I mean, he was not going to be in pain. He's going to be asleep. So if you're not in pain, you're sleeping. So after that, he went and laid down a minute. And once he went to sleep, we went there and grabbed him. Of course, we put a 3-lead on, monitored his heart rate, blood pressure, respiration. He good. He just out. We took him on to the hospital. You know what I'm saying? So sometimes you got to be smart with it. I don't encourage lying to patients, but that probably kept me from getting my butt whooped that night. All right, let's talk about some glands. Glands. We got. All right, we're going to take a quick commercial break. If you're watching this on video, it won't even seem like a break to you. We're just going to pause the recording. All right, we're back at it. Let's talk about the pancreas. Located in the left upper quadrant, retroperitoneal behind the stomach. What does retroperitoneal mean? Behind. Right? So it's more in the back over here, right? The kidneys are in the same spot. Not gonna lie and say I haven't seen a question like that on Registry 2. Has both endocrine and exocrine functions. Main thing we're talking about here when we talk about it in EMS is the alpha and beta cells creating glucagon, insulin. Alpha raises things up. Insulin, beta, lowers blood sugar. So glucagon raises blood sugar, insulin lowers blood sugar. Why is insulin important? Lachlan. Okay, it's the key for glucose to get into the cells. Very good. Also, the pancreas does what? It has digestive enzymes function as well. All right, diabetes. Diabetes. All right, so type 1 and type 2. The most common one between the two is who? Type 2. Type 2. Sometimes people can't help it. They do have a genetic predisposition towards it, but diet and lifestyle can play a pretty big role. Now, one of our own students in here, who shall remain nameless, has had type 1 diabetes since she was 29 weeks old. Okay. Excuse me, was 29 days old. Sorry. So it does happen. Type 1 does happen. That's usually the one that is the juvenile diabetes. That's the one that they're born with, and it comes with all that fun stuff. Type 2 is more common. It's usually older adults. So a type 1 can develop DKA, where that blood sugar starts to climb and climb and climb. They got the 3 polys, right? Signs of it are polydipsia, polyphagia, polyuria. What does that mean? Polydipsia means I'm really thirsty. Polyuria means what? Peeing all the time. Polyphagia means I'm hungry. Ravenous appetite, right? And also their pee has a ton of sugar in it. A ton of sugar in it. How do you know that? Well, yes, you taste it. I'm totally kidding. Scratch that from the record. So we've got DKA being a problem with that. One of the biggest things that we have going on with DKA is what? The dehydration is one of the worst problems. The dehydration will cause metabolic dysfunction, right? So they also have acidity going on. They also have hydrogen ions, the acid, being a more positively charged cation than the potassium. So we have a lot of free floating potassium going on. There's things that we don't do in the field, and that's give insulin, and we don't usually screw with their potassium. For a DKA patient, we need to grab a line and give fluids and help lower that sugar a little bit, but we're mainly treating what? The dehydration that's occurring. One of the big signs that we have is what? Too small. I'm glad y'all bid on that. I'm glad we're all on the same page. Too small respirations, fast and deep, fast and deep. It totally aggravates dehydration because when you breathe out, what are you breathing out? Moisture, water, vapors. The average. Ninja nerd? Nobody likes you.
Master Your Medic.
Master Your Medic.
Podcast. They had awesome. They had some really good things about it.
I agree. The Master Your Medics team, and they have a team of instructors. They're fantastic. And they literally have helped thousands of people become paramedics. This is one of the sites I recommend for you guys to go and spend money on, let them help you. I recommend Pass with Pass, Master Your Medics, definitely any Dan Limmer product. He's been doing this a long time. He's got this on under wraps. And that, of course, emt.nationaltraining.com.
Well, Master Your Medic is pretty good podcast.
The podcast.
Yeah,
And they go
that's why I couldn't help you. I think you just gotta look up Master Medic. Yeah. I thought it was on Facebook.
They have a Facebook group.
They have Facebook. And then they put up they'll put up patient scenarios.
Assessment
And then
and
they'll
video.
ask people for their feedback for the videos, and they'll talk through all the different diagnoses.
And they're very engaging too.
Yeah. Yeah. Do you have the podcast app?
I got a question. Type 2 is way more common. It said right here,
Should have
type 2
the
they
app
don't
or
have
just
the
a podcast?
DKA.
No, they developed the HHMK.
But why do we focus more on the DKA if we see more of type 2 patients?
It is usually due to a confusing of HINK versus DKA, and us having difficulty differentiating in the field. Because what does our blood glucose monitor say? It just says high, But when we're talking about HINK, that thing goes way higher than the DKA will go, right? But we can't really differentiate.
Would they still have the glucose?
Actually, no, they'll be severely dehydrated. They'll kind of be breathing normally. They won't have ketones. They won't smell like the old fruit acetone breath. You can differentiate it, but you just have to be very careful and pick up the subtleties of it. I would say we're going to treat it the same. Main problem they got is they got too much sugar and they're dehydrated as crap. We need to give them fluids and get them to a tertiary care facility that can give them insulin. They need insulin. We don't carry insulin in the pre-hospital setting. At least here in Georgia, we do not. Some
But
services.
they were saying that these problems develop over time, so there's not a lot of food, they aren't impacted. So they said anything that takes time to develop, not, you treat it. That was the.
So gentle treatment, right? We're not gonna dump fluids on anybody. And y'all have all heard my constant water speech about trauma. So I'm not gonna get into it again, but I feel, I definitely support you listening, and they're fantastic. So moving on.
So before you go move on, the biggest child don't have any diabetes. Two simple things. I got a good understanding. Insulin shock compared to diabetes.
Okay.
Which one goes with you? I know it sounds weird. Insulin shock means they don't have enough insulin, or they got too much insulin. But insulin shock means they got too much insulin. And diabetic coma will be they don't have enough. Yeah.
I think you're getting caught up in some terminology issues. So insulin shock sounds like what? There's too much insulin, what's gonna happen? All right, so what's gonna happen? That blood sugar drops and they become altered and now they're a problem for EMS, right? Hypoglycemia, right? Now, have you ever ran a DKA patient? Were they unresponsive?
So that would be the coma.
If we're getting caught up in terminology, that would be where we would stick those terms, but a real patient, though, how to treat them, sugar's too high, throw fluids in there, don't overfluid them, but just give them enough to start helping that dehydration. You don't carry insulin around here, so that's how they need to be treated, get them to the hospital. For the low blood sugar patient, hypoglycemic patient, we got options. A lot of services are using D50. I think it's falling out of favor though, because D50 has 25 grams of dextrose in, right? How much does D25 have? 25 grams. How much does D10 have? There's not the chance of necrotic tissue though, is there? A lot of services are like, you know what? This is much safer, much easier. It may take a minute longer to get in there, but a minute longer is with a lot safer, administration is worth the risk to me, I think.
Yeah, well, I'm with you on that. I'm with you all the way. I'm just like I said, I hate to keep referring back to you, but when the tests I've been taking, and it's just been like you come across a patient has food on breath, he's laying unconscious, you know what I mean?
At this point, the devil's in the details.
Yeah,
One term can turn a question on its head.
Exactly.
All the following except or but or why, these terms can flip us. That's why we have to dissect every one of them with every question we type. And we have to do what? Read every question twice, look at the answers first and find out kind of what they're really asking for. Again, it's not a 180 to 150 question test. It's a one question test. You take 80 to 150 times because you got to treat that one question like it's the one that's going to make you a paramedic or not. You know what to do. At this point, the devil's in the details because of terminology. Even in the fire world, we call certain things down here in Georgia something they would call differently in New York, even from some of the jobs you do. So the semantics of the terminology is important to, understand. But I do believe in you since you were the valedictorian. All right, so a little bit more on how to differentiate between the two here. Type 1 versus type 2. They have beta cell destruction with type 1, very low production of insulin or no insulin production. This is the juvenile diabetes. It's also known as insulin-dependent diabetes mellitus or IDDM. Type 2 either has insulin resistance. So these are the non-insulin-dependent diabetics, right? Some patients may require insulin. It just depends on that diabetic patient. They're trying to do what? They're trying to maintain the homeostasis of 60 to 120, 80 to 120 blood sugar. If you're running high, they're going to want to try and bring you down. If you're running low, they're going to want to try and do what? Bring you up a little bit, right? So it's a sliding scale of what you need. That's why they have to keep pricking their fingers. But I noticed a couple of my students that are diabetics now have that little doohickey thing they can insert in their arm. And I've seen our one student here be like, whoop, ah. And it tells her what her blood sugar is. And we ain't got to sit here and guess. She don't have to prick her fingers. So the advancements that are coming are pretty chill. I would love not to have to stab my fingers on the daily. That sounds uncomfortable. And so it's a sliding scale of what you need. Some patients are put on what? They're put on pills. Some people take shots. It's important to ask your patient what they do. So if we're on pills, we're taking what? The metformin or the glucophage, right? All right, so it's going to lower the blood sugar via that oral pill that we take. Some patients can control their blood sugar with diet and exercise. There are people that have that diet and exercise and actually don't have diabetes anymore per se. There are documented cases of that, you know, but a lot of people just won't change their lifestyle completely or a lot. My grandmother was a diabetic that had to prick her finger and take insulin shots to lower her blood sugar because it would just rise and rise and rise. Then again, she's over there eating Nutty Buddies when anybody looking. What all these paper wrappers in the trash, Granny? That was your uncle. He did that. You still got some chocolate on your face. I only have one. There's 5 over here. So, yeah. All right. So some more information on type 1. I'm gonna keep going because we've already covered all this, but as much information as possible, make sure you go over it for your exam. Homeostasis, we got glycogenolysis, which is the breakdown of glycogen. All right, gluconeogenesis, break it down. Glucose, sugar, neo, new, genesis, in the beginning. New glucose, sugar from non-sugar sources. Both of them are attempts to have homeostasis. So what are we learning about that? Body will break down sugar for energy as necessary. It will create new sugar from non-sugar sources as necessary to maintain what? The balance. Yes. I need some of that going on. Break down some fat. Problem is I keep adding to it. Maybe I'm on another body. So we got the 3 Ps there, just a quick look at them. That's actually from I forgot who it's from. Lights and Sirens EMS. She has a nice Instagram page where she shares information. She does a great job. Most of them look like that too, with the red writing stuff. So DKA versus hyperosmolar hyperglycemic state. The breakdown is again, the treatment's the same. We're going to be doing IV fluids, 12 lead EKG for electrolyte derangements. They need to be transported for insulin. Also to correct any existing acidosis. Hyperkalemia is going to be the big boy. Why? It can kill you. High potassium can kill you. High all PTs, widen QRS, ventral, sine wave, and then V-field. And the reason they give insulin slowly is so they avoid edema. So is it really your job really to differentiate between the two of these? No, I'm talking about DKA versus HHS.
Well, would you think have higher? Yeah, because of the acidotic state that.
Okay, there we go. That's important to know. So either way, the glucometer is going to say high.
Right, but in terms of
I would think that both of them have.
they're not going into acidotic state.
It's worse than
Oh, it's worse. They're going to be like a type of coma, but they're not having the metabolic derangement or the acidotic or the ketones being blown off. They're not going to have that fruity smell, and the pH ain't going to change at all hardly for their body. That's what we're saying. But since we're not checking blood gas in the field, you might not know that. But if he's got a blood sugar that reads high and he's just kind of in a coma-like state and he don't smell fruity and he ain't breathing real fast, we could probably think he's an HHS. Again, my treatment's going to be the same. 12 lead IV fluids, transport for insulin. I would hope prep for possible metabolic derangement. If I see on 12 lead, he's got some hyper K going on, I'm gonna go ahead. Here's a pad, here's a pad. Let's get ready to work.
They were like, like below, whatever it was, it's like a 95%. It was really spot on. So that's an important line, yeah, to differentiate because they're CO2.
So DK is a faster onset. Body switches to fat to burn. So it will be releasing those ketones, too small breath, respirations, ketones on the breath. Blood sugar is a little bit greater than 500. You're technically in DK after you're over 3 though. Now, HHNK or HHS, whatever one you want to call it, this one's slower. The cells are resistant to insulin, so blood glucose levels rise, severe dehydration, and that blood sugar can run up over 1,000.
So how do you really use that? So as
if it's resistant, I suppose you just put enough in there to where it forces the sugar to go in there. So I would say that just put enough in there to where it just happens. Again, possibly just have it sit in the bloodstream. Esophageal varices. I hate for you to trip up on something like this. So usually a common issue with alcoholics, we have swollen veins of the esophagus. They often rupture and hemorrhage. If rupture occurs, mortality rates over 35%. Why is that? Bleeding in the throat, yeah. So causes of this is high portal pressure, liver pressure. So consumption of alcohol, ingestion of caustic substances, liver cirrhosis is about 2/3 of the cases. Painless bleeding and decreased hemodynamics. So they're going to be bleeding out in their throat from the varices, usually caused by the drinking and the liver cirrhosis. Swollen veins in the esophagus. So we've kind of talked about some of this a little bit, but cholecystitis, cholelithitis, pancreatitis. With cholecystitis, any chole, C-H-O-L-E, we're talking about gallbladder. We're talking about gallbladder, we're talking about gallbladder. Again, Register's not going to say his gallbladder hurts. It's going to say chole, something. They're not going to say difficulty breathing. They're going to say dyspnea. So make sure your medical terminology is up to par. All right, so this is commonly caused by gallstones, acute attack in the right upper quadrant. Can occur after a fatty meal. We used to say the 3 Fs. A fat female over 40 that had a fatty meal, and she's got upper right quadrant pain. It's most likely she's an irritated that gallbladder. Murphy's sign is indicative of a cholecystitis and right costal tenderness, hostile tenderness. Now, cholelithitis is actually the formation of gallstones, and it causes 90% of cholecystitis cases. So cholelithitis is gallstones. I saw that on Registry, April 2020. So pancreatitis is inflammation of the pancreas. Anytime you see itis, it is inflamed. So causes will be what? Metabolic, mechanical, vascular, infectious, has a high mortality rate, has a very high mortality rate actually. All right, what about GI bleeds? Upper versus lower. We got upper above the ligament of Treitz. So we got peptic ulcer disease, variceal rupture, gastric esophagitis, a Mallory-Weiss tear, which is again esophageal laceration. And these are some pretty big issues. So what can we have is hematemesis. Break it down. Hema, what you got, Lachlan? Temesis. Throwing up? Okay. Vomiting up blood. All right. Melena is probable. And hematochezia. I might be saying that wrong, but it means all right, blood in the stool, poopy, bloody poop blood. Bloody boo-boo. So below the ligament, we've got causes causing it being diverticulosis, colon lesions, rectal lesions, anal fissures, inflammatory bowel. So let's talk about it. Anal fissures, I would say like a tear in the a tear in the butthole. Like you don't know. You know. All right, so bleeding coming from the butt. If it's bright red coming from the butthole, it's closer to the hole, it's lower. If it's dark, melanin or melana, it's definitely been digested a little bit, right? So it's upper. Now let's go back to the mouth. If you're vomiting up bright red blood, it is a little bit upper. If it's coffee ground emesis, that's red blood cells that have been kind of digested, right? And I've seen it. Now, does the GI bleed smell good? I'm sure you'll never forget it. I like it. Sickle cell. Now, we had probably the best sickle cell lecture that we could have asked for from our friend from Grady that came and gave it to us. I mean, who better to give a sickle cell lecture than someone actually has sickle cell? I really enjoy his lecture and anything he does. So sickle cell disease is inherited, causes an abnormal shape. All right, so the thing we need to worry about is what? It can cause ischemic issues and crisis issues. They can block up the blood flow to an area of the body, and it can cause ischemia issues. So if there's no blood flow to an area of the body, what will happen? That tissue will become ischemic and possibly necrotic. They actually ran a patient at Grady that was a 12-year-old that was having a stroke and a heart attack at the same time because of sickle cell disease. I do not know. So we give IV fluids and analgesics for pain management. We need to take them to a sickle cell clinic or a place that can handle their issue. Take them to a sickle cell clinic. Grady has one. In Atlanta area, Grady has a sickle cell clinic. That's the one I know of. If there's another one, please share with the class. Let me know. Either way, if you're not sure, let's say you don't work in Atlanta and you don't know what's going on, you need to take them somewhere that can handle their sickle cell crisis. This is not something you sit on your thumbs about. And this goes to anybody watching the video. Take them where they can get some help. And the patient actually should really know. That's a good comment. The patient should know where specifically for them, right? And a lot of them, they actually might give them blood transfusions to actually give them non-sickled cells. We don't have those. We got St. Joe. There's no St. Jude here in Georgia. So how do we do it? We're talking about us now. IV fluids, analgesics for pain management. D5W. I'm glad somebody said it. But why though? It's a hypotonic solution. So what is that supposedly doing to the red blood cell?
It's hypo.
If it's hypo, it's pulling it out, right? It's putting water in the cell.
Okay. So it's going to swell them up, right? So it could possibly change that sickled cell to a more round donut look, or at least not sickled and causing ischemia. It could alleviate some of their pain. No, we want to do it. Sure, give them off. There, you happy? Give everybody off. All right, toxicology. Some good to know antidotes. I promise you, one or two of y'all definitely gonna have some question on the National Registry. I gave you a whole PowerPoint. I'm taking pictures. The whole PowerPoint. Access. This exact one, yes. Weeks ago. Welcome to the conversation. I'll help you, boy. Where's he? This is your friend. You brought him in. You are your brother keeper. All right, so take a picture if you want. You do have access to the entire PowerPoint. All right, so good to know antidotes. There's going to be possible toxicology questions on there. Benzos, flumazenil, I beat that into you. Beta blockers, glucagon, calcium channel blockers, you can give more calcium. Cyanide, hydroxycobalamin. Another word for that is B12. B12 shot. It actually inactivates the cyanide. Opioids, Narcan, tricyclic antidepressants, sodium bicarbonate, and dystonia, Benadryl. TCAs is Elavil. All right, so cholinergic, got the sludge going on, salivation, lacrimation, urination, defecation, GI upset, and emesis. What do I give them? Atropine, you know what I mean? If you carry perledoxine or diazepam or lorazepam, do that for the seizures, but most likely they'll ask you about atropine. Dose 1 milligram IV push.
That's what
we're talking about.
I thought you do an extra. Oh, 5 milligrams.
All these other programs.
We'll get 5 milligrams.
You're not even gonna have one.
You're not gonna carry 5.
I thought it was 2 milligrams. I thought it was 2 milligrams.
It might be for your local protocol.
I think in our little pack.
That was one of them plan questions. Yeah,
Oh.
it was 2.
All right, so some more poisonings. Ethylene glycol. Which one of y'all was drinking antifreeze? I about drank some yesterday. I was working on my burger and someone sprayed on me. Windshield fluid. So your job to do what is to give thiamine to degrade the glycolic acid and non-toxic metabolites. Benzos if they seize. What if somebody drinks isopropanosyl alcohol, that rubbing alcohol? Ain't nothing you can do about it. Faith, hope, and love and beach bowling. All right. Metals, iron and lead are most common. Support and transport, A, B, C. Easy as 1, 2, 3. That's what you're doing. Mercury poisoning. They need dialysis. You got that on truck? Oh, is your hand up? Or did you scratch it? Okay. No, you got no dialysis on truck.
Is that related to alcohol, please?
So thiamine is vitamin B1. It helps the body break down carbohydrates and sugars. So if you've got ethylene glycol in your system, it'll degrade the glycolic acid to a non-toxic metabolite. What?
What's in between thiamine and
I'm
One
not,
was B12, wasn't it?
yeah, B1 and
Which
B12.
one gets alcohol? Is that thiamine?
B1, yeah, thiamine,
What you get mad off?
cyanide.
What was the name of it? Methyl.
Hydroxycobalamin. Cobalamin. Sonia Blade. Did we answer your question or look, you're still searching? Are you still confused? Thiamine is vitamin B1. We give that to alcoholics. A lot of services don't even carry it. Only one I know of is East Point. Probably Florida. Bubbles Florida. All right. Now you should have a cyano kit in your engines and your trucks. Last survey I did of the class, and a lot of y'all from different places, a lot of y'all didn't even know if you had one. That'd be a question I'd be asking somebody where I work. Then we got the tricyclic antidepressants again, TCAs, Elavil, amitriptyline. Remember, it'll cause severe hypotension, cardiac arrhythmias, that widened QRS complex. What's the antidote? Odium bicarb. There it is. So calcium channel blocker overdose. We're talking about what? Oh, this is actually from Master Medics right here. They posted on social media. I borrowed it. I did give them a shout out. I've asked y'all to pay for this stuff. All right, so calcium channel blockers. The problem is what? It's blocking all my calcium channels. Remember, for the sodium potassium pump, calcium was kind of important for cardiac contractility. So how do we treat this? The issue is it's a calcium channel blockade, hypotension, bradycardia. Remember, some services give calcium channel blockers to lower heart rate for a stable patient with an SVT or something like that. So now we got somebody that's on 2 months. I hate life, man. Bunch of them. Or it might be granny who don't know what she's doing and takes too many of them. This could happen. So ACLS algorithms for bradycardia, hypotension, but the overriding agent will be calcium chloride. Overrides the calcium blockade. 1 gram IV, up to 3 if you've got calcium gluconate. There's a dose for pediatrics. That's it. Where? Well, that would go into ACLS algorithm for bradycardia and hypertension. See, if it's not a higher tier block, atropine could work for it. I'm not saying it won't, But I think the best way to deal with the root cause is to deal with the calcium blockade that's going to occur from the calcium channel blocker overdose. But I would also think about that atropine to do what? Bring that heart rate up. You know, cardiac output is what? Stroke volume times heart rate. If that heart rate is on the floor, that means my cardiac output is going to be crap. I'm going to have probably hypotension, and causing that will be what? Poor perfusion to my limbs, my organs, my tissues, my cells. I got to correct it somehow. So while I'm getting the calcium channel blocker or the calcium chloride out, I mean, I can throw some atropine in there to try and help them out too. I mean, depending on how bad they are, I might jump straight to pacing or something, whatever it takes. I've got to get the heart rate up. And I need to block, override that calcium blockade there. Make sense? What about more drugs? Sympathomimetic overdose. So anything that's going to rev you way, way up and create a mimic the sympathetic nervous system, right? Anything that's going to mimic it. We're going to have tachycardia, tachypnea, hypertension, diaphoresis, hyperthermia. So the patient I'm imagining in my mind is what I've ran a lot here in the city of Atlanta. They're kind of, reddish. They're hot to the touch. They're sweating. They're scratching. They're itching. They're going all over the place. So the concern I have is excited delirium, which was what? Everything's revved up, causing hypothermia, acidosis, rhabdomyolysis, right? So with that, I've got excited delirium being a problem, rhabdomyolysis, cardiac arrhythmias. Do you think if you do a bunch of cocaine, you might have a couple of arrhythmias pop up? Do you think that might irritate the ventricles and cause a PVC or two? A bunch of PVCs in a row as they run a that could be a problem. Yes, sir. All right, seizure, that's a problem. So seizures are a problem. Don't let them seize. So treatment, if there's non-excited delirium, benzos for agitation. Again, you don't have to knock them out, but you do need to knock them down. So these patients that have done a bunch of cocaine or crack or whatever, and they're way up there, their blood pressure through the roof, their pulses through the roof, they're red hot to the touch, they're sweating everywhere, they're scratching, they got all this going on. Knock them down. Just knock them down. That might be a bit much. Overkill. Horse tranquilizer, something. So we talked about excited delirium. If that's going on, you're going to want to definitely chemically restrain. It could be life-saving. Could be life-saving. We talked about the triad there that could be a problem. We've got hyperthermia, rhabdomyolysis, and what else? Acidosis that could cause a sudden tranquility and cardiac arrest. So if you physically restrain, you're going to want to, all right. All right, TCA overdose, if I haven't made it clear before. Sodium bicarb. Have we picked it up here? All right. What about management for torsades? Or we could do MAG. All right. MAG for torsades. So sometimes as the TCA overdose gets to a different level, it could become polymorphic BTAC or torsades. If that's the case, I'm gonna run with the MAG first. What about beta blockers? We're talking about glucagon. The problem is around here, we don't carry enough glucagon to make that work. The starting dose is 3 milligrams. How much do you carry? 1. We talked about.
So I do.
Yeah, you ain't got a protocol for that anyway. You could always call for permission. Hey, I've got 1 milligram. I could give it in their vein. You want me to do that? They're probably going to tell you no. So with a beta blocker overdose, what would I be seeing happen? Beta blocker is going to block beta 1. What issues would you see with that? Low heart rate. Contractility would be a problem. So I'm going to have a cardiac output issue based on an overdose of the beta blocker. So how would I treat that if I don't have enough glucagon to even start to move that needle away? Epi, dopamine, pacing, something to get the heart rate up, right? So what is my dose for dopamine? 5 to 20. Come on. Come on. Oh, I hate you.
Mike's.
Mike's. You kept going back and forth. I thought it got the hold of those. All right, so mics, 5 to 20 mics per kg. Now, I like to start lower and work my way up because I can always add more. But I can't pull it out of the vein once it's there, right? So I'm looking to put them on 5 mics per kg and see if that gives me the desired effect. If not, I can always increase and turn it up, right? Be very careful, watch your patients, watch for blood pressures, their heart rates, watch for arrhythmias. And what is the danger of dopamine if it gets out of the vein? Necrosis. Dopamine infiltrates, it will destroy the tissue, the skeletal muscle around the veins. Bad juju. You got.
Even in the vein, because your vasoconstricting so much peripherally, doesn't matter.
If we get them high alpha doses, yes. Because I've seen people on Levofed, which is very alpha agonistic, and their feet and hands will turn purple. Better than death, though, right? All right, so we already talked about beta blocker. Aspirin overdose. So, what? You can definitely overdose on aspirin. So what kind of hallmark signs do we have? Tachypnea, tinnitus is a very big aspirin overdose sign. Confused and decreased LOC and respiratory alkalosis. Why would I be in respiratory alkalosis? Ooh, we didn't expound. Very good. So if aspirin is an acid and I am now metabolically acidic, what would my compensatory response initially be? To breathe faster, to try and regulate my internal pH. Very good. Valedictorian of the class. All right, so what can we do to help?
I said, don't blow your head up.
All right, so we already talked about cholecystitis versus cholelithitis. I'm gonna skip this one. Brain anatomy. So let's talk about it. The brain has different lobes and they do different things. Let's talk about that. So occipital lobe does what? Eyes in the back of your head, so vision. Temporal lobe, hearing, memory. If you have a good temporal lobe, you remember that. All right, what about your parietal lobe? Sensations. Frontal lobe is your movement and your personality or lack thereof. No, the cerebellum is the athlete's brain. Yeah, that's your coordination. All right, so the brain receives 20% of the body's total blood flow per minute, consumes 25% of the body's blood glucose. All right, so cervical anatomy, let's talk about it. The spine has 33 vertebrae. How many spinal nerves are there?
No. There's 31. 31, there's 12 in the world.
About to lose my cool. So there
You
are
said it
12.
so confident. I was like, yeah.
It's because you're the loudest for me to write. 12 cranial nerves, 31 pairs of spinal nerves. So how do we remember these? There's 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, 4 coccyx. We eat breakfast at 7. We eat lunch at 12. We eat dinner at 5. We eat dessert at 5. Then we have us 4 margarita nightcaps. What a wonderful, splendid day it was. I actually just didn't have anything for the 4 coccygeal vertebrae, but Tyler Dean suggested 4 margaritas after dessert would be a great idea. So I agree. Yeah, I could go with them right now. Here's your cranial nerves, and a way to remember them on occasion. Our trusty truck acts funny. Very good vehicle anyhow. That goes olfactory, optic, oculomotor, trochlear, trigeminal, abductens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal nerves. Again, you do have access to this PowerPoint if you check your email.
The main ones that I really, vagus nerve, that's 10, right?
Yep.
2.
So I mean, honestly, I mainly worry about in the field 3 and 10. Yeah. Because I'm checking people's eye movements after trauma, like you follow my finger, blah, blah, blah. I'm checking their pupillary responses and stuff too. I cannot say that I have. So that don't mean you won't. All right. Meninges, meningitis. Remember to pad the brain. So pia matter, arachnoid, and dura matter. So dura, durable, outermost layer. Pia, small, innermost, delicate layer. Arachnoids, remember he is the middle guy. Meningitis is a very big, the registry loves to throw that question out there. So any kind of stiff neck, nuchal rigidity, headache with fever, be thinking meningitis. Be thinking meningitis. All right, we done talked about that. We done talked about that. We done talked about that. Long. I be stroking. I like it. All right, we're talking about stroke. So ischemic, hemorrhagic, and TIAs. Let's break it down. Ischemic is about 85% of all strokes. That means that there's a clot that is not allowing blood flow to go to a certain area of the brain, which will cause some actual physical signs and symptoms. So we do perform a Cincinnati stroke scale on these patients. Any altered mental status patient we got, be thinking about doing a stroke scale. Also, before you do anything, you should probably do a blood sugar check. Can't tell you how many times that I've had certain local hose dragging departments try and tell me a patient's having a stroke. I ask what the blood sugar is. They can't tell me because they never checked it. And the blood sugar is like food. So it's important to be thorough. So ischemic strokes are 85% of these things. So hemorrhagic is what? Blood, all right? So there's been a pop vesical aneurysm, some sort of thing like that. Now TIA is a temporary stroke. They show stroke symptoms, but they resolve within 24 hours with usually no deficit. Remember that 24 hours thing, that's important. Check sugars, get a good history. When were they last seen normal? What can you do for a stroke? Transport to a stroke center with interventionist capability, either a TPA medication administration or possible cerebral surgery if necessary. That aneurysm may need to be clipped. Do they do a CT scan before they do start giving patients drugs? Yes. Would TPA make a hemorrhagic stroke worse? Yes. So they have to confirm the stroke with a CT scan, and then they will, if the patient's within the window, they'll give them tissue plasminogen activator, which is the stroke clot buster drug. Yes, that's for controlling bleeding. That's trauma. So they have to do a CT scan first. But what can you do for your patient? One, recognize the stroke signs early, get the hell out of there, call the stroke alert, and take them to an appropriate stroke center. What if you live down there in old South Georgia where I'm from? You can fly them. It's going to take you 2 hours to get anywhere worth of food. So if you can fly, do it.
Is it an hour?
So the new American Heart ACLS guidelines are saying the window's up to 4 hours. It used to be 3 for many, many years. It's 4 now. Yes. I don't know. Never carried it.
That's TPA.
Yeah, the plotting.
Yeah. Assist with trauma and blood bleeding control. I don't know if it goes for TXA. I've never carried it.
I think AMR.
AMR does carry it.
One of them whipped out, started setting up.
That's awesome. However, I do have the dose on this PowerPoint back in the medication section, probably about 200 slides up. You have access to this? Or do you not check your email like somebody else? You got it? It's in there. Before we leave today, before you leave today, I'll pull it up and show it to you.
He said that Grady has like a treatment they can give that's outside of stroke clinic. You know about that?
Not a clue. Maybe we should contact the stroke unit and ask them. I don't know though. So we've already kind of covered all that. Here's a, for you visual learners, ischemic versus hemorrhagic. We've got a clot blocking blood flow. Then on the hemorrhagic, we got something popping and then blood bleeding in the brain. Ischemic, thrombotic, hemorrhagic, TIA, mini stroke. We've already talked about headaches and nuchal rigidity being meningitis. All right, so seizures. All right, so what kind of seizure issues are we going to talk about? Tonic, clonic, grand mal, petite mal kind of seizures. Partial, simple, complex. All right, so generalized seizures are what? He's shaking, moving, and jiving, right? He'll have that tonic phase and clonic phase. What's the danger of a seizure if he's going full-blown shaking, quake? He's not breathing and he's got hypoxia. What do I need to do to stop it? Some type of benzodiazepine or anticonvulsant. Around here, we carry Versed. Do you need an IV for that? Oh, you can give it intranasally. So, stop the seizure. How long would it take? Well, no, I mean, you can give it intramuscularly, but how long would it take to work? 10 minutes. Intranasally will be a lot faster.
We get Versed for
It takes a few minutes for it to work. Yeah.
We have to double the dose.
Yes. If you give something intranasally, a lot of it's not going to be absorbed readily. So a lot of it's, we need to give more than we normally would.
So we would give 2.
I give them 5 in the nose. Stop that season. Now, what about giving a benzo? Don't even remember. Respiratory depression, hypotension. But either way, I can't have them continue seizing. If you got an IV, that's the best thing there is because it activates receptors within 30 seconds. IV is the best. You get there and they get their post-dictor, which means what? Coming out of it kind of sleepy, kind of lethargic. What happened, man? And you're going to be transporting. I'll go ahead and get me an IV. And if it happens again, I've already got access where I can stop it real quick. What is status epilepticus? Tell me about it. They're seizing back. I need to stop that best I can. I need to stop it. Because again, if they seizing, they ain't breathing. All right. Got hypoxia going on. 2 or more. 2 or more.
They say if they last for longer time. Tonic is the tonic the stiff. That's the stiff day, right? The tonic.
Yes. Yes. How about a petite mal? What that? That's what you do during class, right? You just stare off into space, daydreaming, absent seizure. Flash, what does Thomas do in class? Stares off into space, think about anime. I bet Goku could beat Superman. See, I know the theory behind that. Vegeta was trained as a soldier. He was trained to fight many opponents. Goku was always the duelist. That's why he would never beat him.
Superman?
No, I'm talking about Vegeta.
Oh, okay. I thought I said
No, Superman probably.
Yeah, I wasn't even involved in this conversation.
Listen, nerd, you're involved. I've seen your little Nimbus cloud necklace. I know you follow DVD.
I wasn't in the
Sorry, I wasn't paying attention to your nerd speech. Trying to teach about National Registry.
Back to the class.
All right.
But what's wrong when they run like one part? Is that still in part two? Like one side of their body?
Simple, vocalized motor seizure.
Then what's wrong? Because they say, I hear pseudo seizures a lot too. Is that fake too?
Yes.
That's
That's what?
the street terms you use if you don't want to tell somebody they're faking.
Yeah. You don't want to tell somebody they're faking. You can say pseudo seizure.
That's your prayer.
But the old sternal rub has revealed many of pseudo seizures. Attention.
But they do it.
Yeah,
He
absolutely.
broke my heart. I'm gonna have a seizure. Now he feels bad. He loves me.
You see that, like, ATS.
I had
All right, we didn't talk about cholinergic poisoning, so organophosphates, I will keep rolling. Treatment, atropine, prevadaxine, we done covered that. Alcohol use, we done talked about it. There's your thiamine, for who is asking, thiamine, vitamin B1. You'd know that if you had access to this PowerPoint that I sent you weeks ago. Dystonia. So dystonic reaction is when your face is frozen because of the Haldol administration. It's kind of like an allergic reaction. Can be caused by Haldol or Finnegan. Why don't we carry Finnegan? Now you know. Treat it with Benadryl so you can fix that. Endocrine anatomy. All right, we made it. Endocrine. Can you use the bathroom? Yes, you may, but I'm not stopping because it's almost lunchtime. I'm ready to eat. Can you hold it? I mean, you can definitely go. You're an adult. I'm going to continue. It's recorded though. You can always access it. And we can stop at this point where me and you were talking about you going to the bathroom instead of me talking about endocrine stuff. I love you. All right, so endocrine anatomy, we're talking about thyroids, parathyroids, the thymus, pancreas. We've talked about what the pancreas and their thyroid, and excuse me, the pancreas and their endocrine issues are, right? High blood sugar, low blood sugar, how to treat, how to do all that, right? So the thyroid is what normally confuses students. The thyroid is responsible for your metabolism, right? So it's mainly your metabolism. Parathyroid are small little glands. As you can see, those little things on the side over there. Let's activate. These little guys right here. That's what we're talking about right there. These things right here. So it also controls calcium levels. Got a lot of things going on here. So go back. You got access to this PowerPoint too.
Okay.
All right, what you got?
Three is the thyroid. Parathyroid,
Pretty much.
thymus.
So it helps you with your T cells, your immune system cells, cancer fighting cells, things like that. And that's located in the chest. Disappears after childhood. Not that it's gone completely, but you just can't see it. All right. So here's our issues we're going to run into. Thyrotoxicosis, or hyperthyroidism, where we have too much thyroid hormone just pumping out, right? This can be brought on by infection, stress, surgical manipulation of the thyroid. It's often associated with Graves' disease, which has goiter or big neck meat, exophthalmos, big bug eyes. These are issues that we need to know about. Why? So we can differentiate between them, because your registry may ask you about them. Also, so you know how to treat them in the field. Other things you'll see are tachycardia, heart failure, dysarrhythmia, shock, hypothermia, agitation, coma, delirium. How do I deal with all that? The answer is as it comes. What does that mean? I can only treat what I can see. If you're cold, I'm gonna warn you. If you've got severe tachycardia, how severe? Because if it's real severe, I will put the brakes on you with either adenosine, vagals, or some cardioversion. I've got brakes. I can put them on. All right. What about shock? Find some way to increase perfusion. Dysarrhythmia, or what exactly is going on? I got ways to treat dysarrhythmias. All right, leading to Graves' disease. This is excessive thyroid activity characterized by the goiter and big old eyes. Most often occurs in women. Graves' disease most often occurs in women. So now what about myxedema? Or then we got myxedema coma. This is too little of thyroid hormone. Too little. So this is too low. This can also be known as Hashimoto's. Thickened skin, most notably the lips, nose, and mouth. Coma is rare, but it could be precipitated by cold, infection, heart failure, trauma, drugs, stroke, hypoxia. Notice that Graves' disease means that you could be very hot, hyperthermia, and everything's kind of revved up. You got tachycardia and agitation. Myxedema will be you're cold all the time, right? your heart rate will be low. Your metabolism is low. Your cold, low, and slow. Make sense? Too much versus too little. So here's some two ways to differentiate between the two. One's going up, one's going down. One's agitated, one's lethargic. One's hot, one's cold. One's got constipation and one's got diarrhea. You dig into kind of differences? Cushing's, when you got too much cortisol. No, this is something different. So Graves' disease would be the goiter, would be the throat, and the exophthalmos, right? The big eyes, bug eyes. Cushing's is old moon-faced buffalo hump. Got the big fat pad on their back. Probably good for squatting. You never know. So I'm trying to look glass half full here. Too much cortisol. So round moon face, big buffalo hump. I have seen that. On my first registry back 12 years ago when I became a paramedic, I saw a Cushing's question. It really just asked, which one of the following endocrine disorders is being described? And it was basically like big buffalo hump, moon face looking something like that. All right. Yeah, it is. I'm going with some Cushing's here. Addison's, not enough cortisol. So they got hyperpigmentation of the skin. They kind of look like they're laying their tan in bed, but it's got like some splotchy patches going on. Adrenal. Yes. Thyroid to adrenal. Straight into it. And I've got a chart coming up. All right, so Addison's and Cushing's, that'll be adrenal, and then thyroid is myxedemia and thyroid toxicosis syndrome or thyroid. You know what I mean? All right. Differentiation. Look at him. I got pictures for some of you visual learners. So Cushing's, moon-faced buffalo hump looking some gun. All right, Addison's, not enough cortisol. Skinny. See how they got patches of blotchy skin there? Let me get up here and help. There right here. This right here. This right here. Right there. They got vitiligo. Michael Jackson. Yeah. All right. So what about Graves' disease? Graves' disease, they got the exophthalmos. They got the big old bug eyes. They got the goiter. Increased appetite, weight loss, no matter how much they eat, everything's revved up. Hypothyroidism, they're big, they're chunky. You got that low metabolism, they cool, they bradycardic. You got decreased appetite, but they cannot lose weight. In differing degrees, yes. Here's another picture for the Graves' disease if you need it. All right, special populations, make sure you know about those. Things like your cystic fibrosis, Huntington's, Guillain-Barré, Parkinson's, amyotrophic lateral sclerosis, Lou Gehrig's disease. I'm gonna tell you that there might be a special question on there. So knowing how to differentiate between these two would be very important. I had a question on my last one about ALS, which is again the ascending paralysis that starts from the feet, moves its way up to the patient paralyzed. They usually die around the time that their chest gets paralyzed. Who can think of probably the most famous person with ALS besides Lou Gehrig in recent times? No, he's thrown from a horse. He just had a spinal.
The guy on that TV show on Fox.
I think you're wrong.
Terrence Howard's character.
I think you're wrong. Who is the guy?
That show on Fox, but yeah, you're talking about that. He had ALS.
How do you not know his name?
Oh, Stephen
Hawking. Okay. Very good.
I don't know, he was alive forever.
Yeah, he lived a long time to have ALS. He was told he was going to die. Like a year or two ago. And that, my friends, is the medical section of your national registry. So is this all inclusive? No, it's not all inclusive, but it's a good start, a good base to build off of. I would say know as much about the medical section as you can. Any questions, hit me up on my email. Anything I can share with you or help with, please let me know. And we'll catch you next time.